implementing outpatient antibiotic stewardship, part 3. Our objectives of this series was to discuss our CDC core elements, which we did in part 1, identify barriers to improving our outpatient antibiotic utilization, which was part 2, and then create SMART goals for antimicrobial stewardship initiatives. And so we're going to go over today um, our SMART goal, and I created one that we're going to talk about, and we're going to discuss that, and then we'll go through the necessity of antibiotics, and we're going to break down the SMART goal into actionable pieces. As a reminder, we talked about SMART goals in part 2, but SMART goals are really to make sure that we set a goal that is specific, measurable, obtainable, relevant, and has a specific time on it. An example of that is specific is really having that clear goal in mind, not just saying let's lower fluoroquinolone use, but instead say lower fluoroquinolone use by 10%. And to be measurable, you have to be specific, or sorry, you can't be specific without being measurable. So that's why that 10% on that goal. You want your goal to be obtainable. You don't want to say, let's lower it by 90% when we know that that probably isn't going to happen, or it's going to be really difficult. You don't want to set yourself up for failure. And then we want to make sure our goals are relevant to our patients and that it'll make their care safer or have better outcomes for them. And then time bound. You always want to make sure that you have a time frame on your goal, so that we know whether we made it or not, and that you get your goal completed. Okay, so I am going to I used the SMART goal worksheet to create a goal. And we're going to go through this worksheet. So my initial goal was to decrease the number of prescriptions written for antibiotics. Now let's make this a SMART goal. So in the worksheet, we talked about being specific. Think about what you want to accomplish, who needs to be included, when we want to do our goal, and why is this a goal. So my thought was, I want to lower antibiotic use by providing education to all the staff. And the people that I need to be included need to be providers, nursing staff, clinic managers, lab personnel, and I might have forgotten somebody, but a large group of people need to be involved. When do I want to do this? Probably starting in the fall. And I want to do this goal because resistance to antibiotics continue to rise, and too many patients are having adverse effects to antibiotics. So my goal needs to be measurable. So how can I measure the progress and know if I'm successful? Well, on this goal, I could potentially calculate the percentage of visits getting antibiotics, or compare the number of prescriptions written for respiratory illnesses. And then I would want to review this pre and post intervention so I know if I made a change. That makes it measurable. Is it achievable? Do I have the skills? And if not, who or what should I do to obtain them? What is the motivation of the goal? And is the amount of effort really on par with what the goal will achieve? So for this, I will need probably IT support to help build a report or actually pull the data for me. The motivation for this is really to meet a priority element of antimicrobial stewardship, which is to review a disease state for evidence-based prescribing. So we could review antibiotic use by indication, so by a respiratory illness, to see if we are following guidelines. Is this relevant? Why am I setting this goal now? Is it aligned with the overall values? Well, 30% of outpatient antibiotics are unnecessary, and guidelines list never antibiotics for viral infections, such as influenza and RSV. And the overall value is of doing no harm to our patients. And inappropriate antibiotics can actually do harm to patients. So yes, this is a relevant goal. And time bound. How can I make this goal time bound? Well, respiratory season is in fall, winter. So we won't receive results overnight. So maybe a year is a good framework for this work. So in the end, working through this worksheet, my goal changed from just decrease the number of prescriptions written for antibiotics to lower antibiotic prescribing for bronchitis, influenza, RSV by 20% in 1 year. And I will provide monthly education on each topic, symptoms, testing, treatment guidelines to all staff. So one thing you might want to think about when we're talking about our SMART goals is think to yourself, what antibiotics are being prescribed in your clinic or facility, and what are the indications? Is there something that stands out that you use a lot of? Or why are we prescribing for bronchitis? Or bronchitis is our number one antibiotic indication. Things like that. What stands out that you can work on? So what I look at is what antibiotics or when antibiotics are needed. And when we look at this, community-acquired pneumonia, it's hard to know if you have a viral or bacterial pneumonia, so you're going to probably, more than likely, prescribe antibiotics for that, which is appropriate. But sometimes when we look at things like pharyngitis, sinusitis, and acute otitis media, we don't always have to give antibiotics. And so those are sometimes antibiotics. And then there's ones that we should really never be prescribing antibiotics for, such as influenza, RSV, acute viral upper respiratory infections, and acute bronchitis. Because those are viral infections and antibiotics really will not do a thing and you could be causing harm to your patients. So for my goal, I picked our never indications for antibiotics to focus on. But I'm going to use this as the way of communicating to staff on different infections. So what I did was I created a little PowerPoints that I can give out on a weekly. I can just email these little slides to have people look at, or you can use them as a huddle topic, a quick little reminder, a couple minutes here and there to really drive home and focus on over this, my year of my goal, to achieve my goal, to really help keep focused on that. So I'll kind of go through these. These are both to help drive our point of our SMART goal, but also as a review of things to think about when you're making a SMART goal, of areas that you might want to think about tackling to really reduce your antibiotic use. So influenza, there's 3 to 11% of the population has symptomatic influenza in a typical year. There's almost up to 1 million hospitalizations. There's up to 80,000 deaths per year because of influenza. And the typical season is October through May. And it is just preventable by using a vaccination. We test for influenza in a couple different ways. There's rapid direct antigens. It's it's highly specific, but it's not very sensitive. So this one's quick. It's a 10 to 15-minute test that can be run, but it's better at predicting or detecting influenza A than influenza B. More places you really use this rapid molecular assay, and this is more common in outpatient settings. It's highly sensitive, highly specific, takes 15 to 30 minutes to run, and sometimes can also detect RSV depending on the test that you have. And that's like the most common one. And then we also use PCR testing, and we'll talk a little bit more about PCR testing when we go into RSV, but that's another option, and that will help show other respiratory illnesses besides influenza. Treatment, again, is no antibiotics are recommended for uncomplicated influenza in the absence of pneumonia. If the patient presents with influenza plus pneumonia, well, you're giving the antibiotics for the pneumonia, not for the influenza. We do use antivirals. They're different than antibiotics. They can be used in our high-risk groups. Those high-risk patients include those with severe or progressive illness, chronic medical conditions or immunocompromised, children that are less than 2, adults greater than 65, and pregnant women are our high-risk groups. We want to start antivirals as early as possible. They have the best efficacy the earlier we start them, but up to within 5 days of symptom onset. After that, the value definitely goes down for our patients. I listed 3 antivirals that are commonly used for influenza. But also remember that we can offer symptomatic treatment for our patients and residents as well with acetaminophen, non-steroidal anti-inflammatories, nasal decongestants, oral decongestants, or like dextromethorphan, guaifenesin may also be beneficial for patients with influenza. So other options to provide versus antibiotics, which will not help our patients who are suffering from influenza. RSV circulates in the fall and in the spring, and the symptoms often depend upon the age of the patient. Older children and adults really have cold-like symptoms. Less than 2, they sometimes present with fever, decreased appetite, and a progressive cough. Patients that have bronchiolitis or inflammation and congestion of the bronchioles, RSV is a known cause of that. And then there are vaccines out there for prevention as well. Testing can be done quickly in a clinic as well. There's rapid antigen testing, which is usually used for infants and children less than 2 years of age. And then there's the PCR, which is usually the older children and adults. And that's usually, like I said, part of a panel. And that really will help detect other respiratory viruses as well. So that one's really nice and a good thing to do because if you end up with a positive virus on there, we would not give antibiotics. So if you get a positive RSV, like I said, no antibiotics, but there is supportive care we can offer. Nasal bulb suctioning for our little kiddos, ibuprofen, Tylenol, making sure that they're staying hydrated is really important as well. And then for follow-up on this one, something to think about is that symptoms should improve or peak around day 5 of the illness. And that's a good communication point to patients as well, so they know what to expect. But also have a follow-up plan that they can return to the clinic or call the clinic if symptoms at day 10 have not improved or are anytime if they're getting worse. That's important to share. Another thing we see is viral upper respiratory illnesses. It's the third most common frequent diagnosis in office visits. There's over 200 viruses that can cause the common cold. Very unspecific symptoms: fever, cough, runny nose, nasal congestion, throat, headache. All of those are like your upper part of your body. When we get all those, that's usually the common cold, and antibiotics are not going to help that. But we can offer symptomatic relief once again so that our patients aren't feeling like they're leaving empty-handed and that we're not using antibiotics for these patients. A very common diagnosis that we see antibiotics used for, which would be inappropriate use of antibiotics, is for acute uncomplicated bronchitis. The symptom really is a cough for these ones. And really, symptomatic relief is a good way to handle these. Also, a lot of times we don't get chest imaging with bronchitis either. So it's not always indicated to get that. But antibiotics really should not be used for bronchitis. It's a lot of times is viral. Acute otitis media in children. This is a sometimes. Sometimes antibiotics are appropriate for this, but sometimes they are not. A lot of times, otitis media will self-heal, to say. It'll improve and symptoms will go away usually within 5 to 10 days. I know this is hard for parents. I've had kiddos with acute otitis media, and it's tough to have them be uncomfortable and in pain and not be able to feel like you're helping them. But antibiotics are not always the option. 4 to 10% of kiddos that are treated with antibiotics will experience an adverse effect, so we don't always want that either. Treatment, a lot of times for our young ones, it's just watchful waiting and making sure that they do get better, but a lot of times they will get better. If we end up deciding we need treatment for these patients, we would use like amoxicillin or amoxiclav, or if there's an allergy, then ceftonir or one of the other cephalosporins would be appropriate antibiotics to start with. Sinusitis. How many on here think about have you gotten an antibiotic and said you have a sinus infection? Well, sinus infections are really viral. 90 to 98% are caused by a virus. So we really do not need to be giving antibiotics out as much as we do for sinus infections, as they are very much viral. There are certain times we'll get into when antibiotics are appropriate. But one thing to note is that colored sputum is not an indication of a bacterial infection. Postnasal drip and runny nose, that can be a sign that you might have a bacterial infection as well, but not always. This could be a viral infection as well. So the color doesn't matter in this one when we're talking about acute sinusitis. Now, chronic sinusitis, that may be a different story, but for acute, the guidelines say the color does not matter. When to consider it being a bacterial infection is if patient has persistent symptoms without improvement for greater than 10 days, or if their symptoms are worsening, or they get a new or onset fever, or if the patient gets better and then symptoms worsen after they get better. Or the other way for it possibly being bacterial is if they have a severe symptoms, fever greater than 39, purulent nasal drainage that has lasted at least 3 days. Those are signs that they may have a bacterial infection. And note, it says purulent drainage. It doesn't say green. It doesn't say yellow, just purulent for more than 3 days. Treatment, we can use watchful waiting. That's common, especially if we're thinking it's viral. Or there is first line agents is amoxicillin or amoxiclavulanate. Second line, you could use doxycycline or levofloxacin. One thing, how many of you have gotten azithromycin for a sinus infection? It's no longer recommended as there's been higher levels of strep pneumoniae resistance. So a Z-Pak or azithromycin for sinusitis is truly not recommended anymore. The other thing that we talk about is laryngitis, and that's a sometimes antibiotic one as well. Only 5 to 10% of adult sore throat cases are actually caused by group A beta hemolytic strep. And that would be the only indication to give an antibiotic. Symptoms of laryngitis, fever, tonsillar exudates, tender lymph nodes, but no cough. That's a big thing here is that there isn't usually a cough with this one. Testing would be a rapid antigen detection test. We usually treat or test patients that have 2 or more symptoms. And if they test negative, we don't treat. They have to have a positive culture or test to treat. Treatment, again, here is amoxicillin or penicillin. And then if they're allergic, we can use cephalosporin, clindamycin, and macrolides are listed as options, but there has been increasing resistance to those. And normally duration would be 10 days. So just a side note, when we treat patients inappropriately for laryngitis, they're more at risk for C. diff. In children, they're 8 times higher, a greater risk, and adults have 3 times higher risk of developing C. diff when we treat it inappropriately for laryngitis. Okay, so let's go back to our SMART goal. So we talked about our SMART goal, and my goal is to lower antibiotic prescribing for bronchitis, influenza, and RSV. So let's break this down a little bit further. And we're going to kind of go into that worksheet a little bit more. So what are we going to measure for this? Well, I'm going to create a report that pulls specific ICD-10 codes and antibiotics at a same visit. Then I can know the number of prescriptions that are being given per the indication. But I want to know like who's getting them, who's not. So I want to know the percentage of visits per indication that receive an antibiotic. So then I'm going to create a report that pulls specific ICD-10 codes, compare the number of visits who received antibiotics versus those that did not receive antibiotics. And I'm going to pull this data as a tip. I'm going to pull it before I start my project so I have a baseline. And then I have to determine at what period do I want to review this again? Do I want to review it 3 months, 6 months, a year from now to pull that data again? It really kind of depends on your time and when your project and when to review. So we talked about attainability. To know if this goal of reducing our bronchitis, influenza, and RSV is attainable, I would work with my group that I'm going to work with this on. Discuss with that group and say, what percentage should we lower it by? And see what the group consensus is. And then identify your barriers, and strategies to overcome them. Is there a person in your working group that you know is going to protest a change? If there is, and you identify them as a barrier, invite them to be part of your group. Include them in, and so that they can help vet and you're addressing your barrier while making your goal attainable. And then always, how are you going to communicate this out to everyone that involves? That's always a good point. Communication is really important when you're working on your goal. So our group and my group decided that we're going to lower our bronchitis, influenza, and RSV antibiotics by 20%. So is it relevant? Is this going to improve patient care or cause harm? Is a great question to always ask. And in this case, I think it's going to improve patient care because we shouldn't be giving antibiotics for these indications so that we're helping to prevent harm. We're helping to prevent resistance because we're not using antibiotics when they're not needed. Is this evidence-based treatment guideline? Like, yes, it is. In guidelines for these 3 diseases, it does talk about not using antibiotics, so that would be evidence-based treatment. And then a good question is, do you see this type of patient in your clinic? In a walk-in clinic, this SMART goal would be great. In a dialysis clinic, this SMART goal may not be so applicable. So really making sure that whatever goal you pick is relevant. And looking at relevance sometimes deals with cost as well. And this is an example from the Pew Trust on the cost of inappropriate prescribing, not just the cost of medicine, but of the complications that can occur when we inappropriately prescribe antibiotics. And for this goal, looking at this by upper respiratory infections or the common cold, almost $19 million in complications due to inappropriate prescribing of antibiotics. Pharyngitis in children's, it was 21 million. In adults, almost $50 million. And so it might not be on that scale at your clinic, but it helps and it improves patient care. So lastly is timing. TikTok, time's a ticking, right? So what is the time frame of your intervention? And then how often are you going to monitor your progress? And then making sure that you report it out to everyone involved is really important. So in this goal, that is why we said we're going to lower these antibiotic prescribing for these 3 disease states by 20% in 1 year, because a good year of data is really good, especially when we know we have fluctuations and when we see our patients and when we know our viral respiratory illnesses are really higher in the fall, winter, and usually less in the spring and summer. So then we get a full picture. We're not just seeing our highest times where we prescribe or our lowest times when we prescribe. It's a good time frame to use. So that is an example of working through a SMART goal. If you guys have questions about SMART goals, I'm always available to help with you and work through them with you to make sure that you have an excellent SMART goal and you're set up for success. So that ends our show today.